Hi, everyone. Thanks for joining me. I am excited to chat with you over the next half hour or so about a topic that is dear to my heart. We're going to chat about hormone therapies for women and differentiating our biases, beliefs from the facts and what we know. So as we do that, we have a few objectives to keep in mind. Our goal, of course, is to identify if we have any biases that we bring to the table, whether we are patients or providers. And then we will address some of the most common myths, misconceptions, beliefs that we have around hormone use and kind of counter that with what we actually know using the current data. And ideally, as practitioners, we'll be able to bring some new points to the table to discuss with our patients and help them make some personal decisions. And for anyone joining us who's not a practitioner, we're going to discern some of that so that we take away some of the noise around hormones and hormone use and risks versus benefits, so you can ideally make some education-based decisions for yourself. I'm Dr. Robin Kutka. I'm a naturopathic physician and women's health coach. I am an independent clinic owner and have been in practice for over 15 years. Previously, I was director of clinical services for a laboratory where I had the opportunity to teach other providers how to interpret salivary hormone panels and safely and effectively use bioidentical hormone therapies with their patients. So I have viewed over 50,000 hormone panels, and I've used that knowledge to really tailor my practice to work exclusively with women for hormone therapies. I do that in a one-on-one fashion like you're used to, and also in online programs as well. In addition, I also teach other practitioners with a mentorship. So when we're thinking about practicing medicine, working with patients, and patients, presenting and working with doctors, it's hard for us not to bring our beliefs to the table. And of course, some of that is going to seep in some regard, but really we want to make sure that what we're basing our decisions on and what we're presenting is fact-based, based off of what we know, not necessarily our own life experience. If we're doing it off our own life experience and our own beliefs and our own opinions, we're taking that onus and autonomy away from the patients to be able to do that for themselves. So I want to take a moment and explore our internal dialogue around hormone therapies and what we think of them. What's interesting to me is in medicine, I don't really know any other topic that is this charged or this focused on someone else's belief versus the therapies and things that we have available, especially when it comes to talking about menopause and that menopausal transition and the hormones and quality of life issues that women experience during that time. So on the next slide, we're going to see a few different words. I will run through the words. I'm just going to say the words. I'll give you a couple seconds, 3-4 seconds. And I want you to just acknowledge whatever comes to mind first, whatever word pops in your head. That's what I want you to acknowledge and just be aware of. And no judgment here, whether they're positive, negative, or neither, just kind of there. So our first word, menopause. Hormone therapy. Estrogen. Breast cancer. Now, if you jotted them down, that's fine. If not, that's okay too. But I want you to take note and see, the things that came to mind. Were they negative? Were they dismissive? Were they uncharged? Were they positive? Where's your own thought process around this? And that's fine to have your own thought process, your own opinions, your own beliefs. We're going to go through some of these things. We'll see if that changes. It may or it may not. As long as we are acknowledging that those are the beliefs, opinions, and feelings that we own, and we aren't projecting those onto others. This is One of the most extreme cases that I've seen in my practice of bias leaking into, or bias and belief leaking into care. Now, I understand that as practitioners, what we're doing for our patients, we're doing it because we feel it's the right thing, it's in their best interest, and ideally it's done with love. But in this case, we're going to see that for this woman, it really wasn't in her best interest. So this is one of my patients who came to my clinic in June of 2021. She was at the time 53 years old and postmenopausal. She was coming in for continued management of multiple concerns, including hormone therapies. Now, I've been working with her for years. This isn't a new patient or anything like that. She was already using an estradiol patch, sublingual progesterone, that's progesterone that's dissolved under the tongue, and an oral DHEA supplement. Prior to this visit, she'd been having some back pain and she went to urgent care for an acute instance, like she should have. It was about 3 months before this visit. At urgent care, she was given very standard medication, so anti-inflammatories and muscle relaxers. When she came in to see me, she was complaining of fatigue, return of her mood concerns and depression, brain fog, and low motivation. This is where she started when we started working together. So it was odd to see her back here. So in further discussion with her, she reports being told to discontinue her hormones cold turkey, as she couldn't use them with the prescriptions that she was given at urgent care. So from the urgent care doctor, what she heard was to discontinue her hormones because she couldn't use those with the anti-inflammatories for her back pain. Now, looking at her prescriptions, there's absolutely no contraindication here. Everything was fine. There's not even an inkling of a potential contraindication. So this is most likely a scenario where someone was concerned about her medications and hormones themselves and had her stop, which of course severely and negatively affected her quality of life. But when we have these ideas and thoughts, of course, they aren't unfounded. They're there for a reason. They came about because of something. And when it comes to hormones, our foundation for these thoughts of hormones potentially being dangerous, maybe increasing the risk of breast cancer, being bad for women, comes from the initial findings of the Women's Health Initiative. The Women's Health Initiative was a very large study that looked at women using hormones and was stopped abruptly because what they found was that women using this, Prempro was what was used in the study, and I'm going to expand on that in our next slide, but women using Prempro had a 41% higher incidence of stroke, twice the rate of blood clots, and an increased risk in breast cancer. What's interesting and important to note here is that increased risk in breast cancer that they saw was almost statistically significant. So it wasn't even statistically significant, yet we've really grabbed onto that as this big concern that came out of this study. So what we need to know about the Women's Health Initiative is that the women in this study, they were using Premarin. Premarin is conjugated equine estrogens, of which, so this means it's conjugated estrogens from horse ear, and that's what equine is. Equine or equine is horse. Of that, 50% of that is estrone. That is an estrogen that's found in the female body, but we do not use in hormone therapies any longer. It's a tiny bit of estradiol. That's our main estrogen we do use in hormone therapies, and multiple other estrogens that aren't found in the female body. But that's probably not even the biggest part of it. We have to realize that these women were swallowing estrogen. It was an oral delivery. Many of these women were or had previously had a hysterectomy. So those women were only using the Premarin. Women who did have a uterus and had not had a hysterectomy were using what was called Prempro, which is your Premarin with medroxyprogesterone acetate. So MPA or progestin. And that's really important here. So two big important things is we're using oral estrogen in this study and progestin. Not progesterone. Progesterone is what our bodies make. Progestin is what's in birth control. So the other thing to note here is the average age of participants was 63. And as we move forward, you're going to find out why that's important. What's really clear, what we know now, and you're going to see this over and over in the next half hour, is that our route of delivery matters, especially when we are talking about estrogen. Oral estrogen, when we swallow estrogen, it has to go through the liver, just like anything else we swallow. And when that happens, multiple factors, multiple metabolic changes occur in the body that together, when combined, increase the net prothrombotic potential, or the net potential to make a blood clot. Topical or transdermal estrogen, estrogen supplied through the skin like a lotion or a patch, has one change. That does not increase our net prothrombotic potential. It does not increase our risk of having a blood clot. So very different, even though we might be talking about the same hormones, whether we swallow estradiol or estrogen, or whether we apply it topically, it has very different effects on the body. And we know transdermal or topical estrogen has a safer side effect profile. Progestins, as I mentioned, are not progesterone. They do both bind to the same receptors, but progestin protects the uterus from the gross effects of estrogen, as does progesterone, but that's really the only benefit to progestin. Progesterone has a lot of other benefits, thanks to bone health, brain health, breast tissue, our mood, weight, all sorts of goodness. Progestin doesn't have that. So from an action standpoint, the only thing they share is they can both protect the uterus. They have different molecular structures, so they're made up differently. And progestins, unlike progesterone, may have many negative side effects to our health. I actually I coined the term the magical unicorn of hormones. That's what I think of as progesterone. It does all these amazing things for women. It helps us feel better. It's relaxing. It helps us sleep without any known health risk, unlike progestin. So we love progesterone. It's fabulous. As I mentioned, they're molecularly similar. What I would like to point out, let me just move this bar down here for us, or maybe even over to the side. Let's see what we can do there. Yeah, and then we'll move there we go. What I will point out is that progesterone and progestins have more molecular differences than estrogen or estradiol and testosterone, but we would all agree and acknowledge that those are very different from each other. So take home here is that they're different, they're not the same, yet many providers, many journal articles, were still interchanging the words as if progesterone and progestin are the same substance, and they are not. Okay. So if we fast forward 20 years post the Women's Health Initiative, what we now can know is that hormone therapies are generally considered safe. They have multiple benefits for women, and risks correlated with their use are typically pretty small, if not null, like maybe even nothing, depending on what a woman's using. Hormone therapies can be beneficial for menopausal symptoms much beyond hot flashes, things like mood, sleep, aches and pains, hair, skin, energy, all sorts of goodness. They can be beneficial for bone health, brain health and cognition, libido, urinary symptoms, vaginal dryness, weight management, breast health, cardiovascular health, and overall longevity. So how long we're living. But is that the story women are getting? So those of you joining us who have kind of dabbled into the world of hormone therapies, whether you're a practitioner or a patient, are probably realizing that's not the story women are hearing. So what we have here is a list of things that I have heard women tell me they've been told by practitioners, or by friends and family. And so these are still the things that are seeping in. So women might seek care only to be told, it'll be over soon, just write it out. Hormones are dangerous, they're too risky. Hormones cause breast cancer. You're too young for menopause. Everyone experiences it, just live with it. Or it's not that bad. You must be depressed, take this pill. You're too old to start hormones. You're too old to continue hormones. You have to stop them. And I'm not managing that. These are things that women are hearing, and it's time we change this story and use the facts that we know to present choices to women and make their own decisions. So why are they hearing this? Well, as providers, we might have an inadequate understanding of cause and effect of menopause, not only as providers, but patients too. Um, Lack of awareness of current hormone therapy options. There's not a lot of education or training around this. It's not making it to our providers, and providers are busy. They don't have time to dive into this on their own. There can be some gender bias and stereotyping here by both, again, providers and patients, friends and family. There's an underrepresentation of menopause and perimenopause in articles that are presented to our OB/GYNs and for continuing education. And we have an absence of universally accepted diagnostic criteria for hormone imbalance, menopause, things like that. So it just all translates into a lot of confusion for everyone. So we're going to move away from the confusion, explore some of those notes that we might be telling patients or patients might be hearing, and explain what we actually know so we can bring that to the table. So for our first one, I've heard this from patients, I've heard this from providers. Isn't menopause a natural part of life? Why would we treat it? It's natural. Everybody goes through it. Well, that's not wrong. Menopause is a natural part of life, but our medical, societal, technological advances, they've significantly increased a woman's lifespan, and she can spend up to half her life in menopause. So why wouldn't we make that optimal? Like, let's not spend that half of life feeling crappy and low quality of life. Let's make it amazing. So as a reminder, menopause is actually considered 12 consecutive months without a cycle. That's menopause. The average age of menopause in the US is about 51, but it's considered normal, if not early, but normal as early as age 40 to 42. And it's estimated that 6,000 women reach menopause daily in the US, with over 1.1 billion women expected to be postmenopausal worldwide by 2025. And it's not just about hot flashes or how a woman's feeling. This is a $1 billion issue. We lose almost $2 billion in lost working time per year because of the symptoms and experiences of women in menopause. A third of working postmenopausal women report job performance has been negatively impacted by their menopausal symptoms. And in this particular study, over 83% of respondents who had experienced menopause said it negatively affected their work. That's huge. That's the vast majority. And besides being negatively impacting to societal finances and to work, there's, of course, relationship impacts. This study was done by an attorney's office. They do this yearly. And what they found is that over 75% of women felt that their partner didn't have the knowledge or resources to support them through menopause properly. Almost 70% of divorces involving women at this time of life were initiated by the wives. I ask all of my patients when we start working together, if they're thinking about divorce or whatever, of course, make their own decision, but I ask them, let's try to refrain from making any big life decisions over the next 2 months until we get your hormones balanced. Of course, we don't say that if there's, domestic violence or there's danger in the household, but if we're starting to make a big life change, try to get those hormones balanced first and reevaluate and see if you want the same change. 65% of women here stated that their menopausal symptoms or perimenopausal symptoms affected their relationship. And over 70% of women blame menopause for a breakdown in their marriage. Of course, we can also have a lack of intimacy, increased arguing, and decreased communication. So the bottom line when it comes to, isn't menopause a natural part of life? It is, but it's impactful. And addressing hormones is extremely important for quality of life factors and health in the long term. So what about this one? Just write it out. It can't be that bad and it'll be over soon. Well, This is a really surprising time of life for women. The conversation is starting to take place more and more frequently. We see it on social media. We've got our doctors on Instagram, our influencers talking about it. There's a lot of noise out there, and I'm happy that the conversation is happening. But this is still a surprising time of life for women. On average, women experience 7 menopausal symptoms. That's average, some more, some less. Over 40% reported them to be worse than what they expected. And at least 20%, I would venture to guess this is more, but at least 20% of women aren't expecting common symptoms, things like sleep disturbance. Women equate menopause with hot flashes, and a lot don't know that things like sleep disturbance, mood changes, increased anxiety, dry skin, those are also common symptoms, and women don't know how long they can last. Of course, we saw there's a negative effect on work and relationships. They're reluctant to talk openly or consult with a healthcare practitioner, and they report feeling isolated. And many of them consider the information and support that is available to be insufficient. And as a reminder, perimenopause, or that time leading up to menopause. So menopause is our 12 consecutive months without a cycle. Perimenopause is the time leading up to that. It's not a light switch. It's not on, off. It can take 8 to 10 years, plus or minus 5. So this can be a significant amount of time that women are experiencing these hormonal fluctuations that are causing these negative symptoms. As a reminder, it's considered early but normal as young as 40. And because that transition can take so many years, in younger women, these hormonal shifts can be overlooked. Think of somebody who's 35 that is going to become menopausal at 42. She might hear, "You're too young for menopause. You're too young for hormone shifts." She's not too young for hormone shifts. She can absolutely be experiencing them. Vasomotor symptoms are hot flashes and night sweats. This is it's an excerpt from a study that looked at the duration of these vasomotor symptoms. And what they found is that women who had frequent vasomotor symptoms, I don't recall exactly the frequency, but it was something like, a couple a day over the 3 weeks preceding this. So it wasn't a lot. But it lasted, they found that those women had symptoms that lasted more than 7 years during the menopausal transition, and persisted for almost 5 years after their last menstrual period. So just because we go our 12 consecutive months doesn't mean that symptoms stop. So it's not necessarily over soon. For these women, they had almost 12 years of hot flashes. How miserable. And what they concluded, which I would disagree with, is that healthcare professionals should counsel women to expect that frequent vasomotor symptoms could last more than 7 years, and they may last longer for African American women. And what they missed here is the part where we can do something about that. Beyond hot flashes, of course, there's a multitude of other symptoms that can happen. We've already touched on these, so I won't go over them again, but they're here if you want to review. And the bottom line here is that symptoms of hormone imbalance and hormone changes during the menopausal transition significantly impact quality of life and relationships for many women. And they don't stop just because a woman becomes menopausal. We have a lot of low risk options that can address symptoms for women and give her back her quality of life and relationship. Dismissing these symptoms and withholding treatment is doing a disservice to women. Ladies who are not practitioners listening to this, something that I like to remind my patients is that doctors work for you. Your healthcare practitioners work for you. You get to build your team. So if you feel like you're being dismissed, if someone isn't listening to you, if you're not getting the treatment or the results that you want, you have every right to fire that practitioner and hire a new one. Build a team that works for you. That's the goal. We are not all going to be great fits for every patient, and vice versa. So our next one we're going to look at is, I asked for hormone testing and was told no because it's pointless. She was told, no, it's pointless because hormones will show low since you're in menopause, or testing isn't needed to start hormone therapies. Hormones fluctuate too much to test them accurately. So why is she told this? This is because our conventional approach is a one-size-fits-all approach to hormone therapies, and many providers don't understand the difference between our testing options. Most providers continue to use blood levels, which is not usually helpful in this situation. And reference ranges, or what we compare a woman's results to, they're set by an average of other women having their labs drawn. So they're just an average, and they're large. So what happens is if a postmenopausal woman's having her blood drawn, and we have, let's say, 1,000 women with their blood drawn, we're just going to set reference ranges basically to average that out. And so most likely you're going to have your labs drawn, they're going to fall within the range, and it will look normal when compared to them. So there's no clinical relevance. There's nothing we can do there. Basically, we're just telling everybody, yeah, you're all, menopausal or premenopausal, depending on where you are when your labs are drawn. And we already know that. So our one-size-fits-all approach, which is still mostly used today, if a woman is symptomatic, she gets estrogen. Does she have a uterus? She does? Okay, she gets a progestogen, hopefully progesterone at this time. And if she's not, she gets estrogen only. That comes from the Women's Health Initiative that showed us progestin can increase or has risks with it, where progesterone wasn't studied there. And even though it doesn't have risk, it's treated as if it's the same thing. So it's thought of as just uterine protection. We forget that it can help us with mood, with sleep, with those other things. So this is our one-size-fits-all approach. I do not agree with this approach. We're going to see my approach. In this approach, women can become more symptomatic, remain imbalanced. Maybe they get a little bit of symptom relief, but I very rarely see women getting full symptom relief with this approach. I think this approach is flawed. We know that the symptoms of hormone imbalance overlap. So hot flashes, for example, can be low estrogen, low progesterone, fluctuating estrogen or progesterone, or a change in both. Women can make estrogen in their peripheral tissues, in their fat cells. So even though we're becoming postmenopausal or we are menopausal, we're still making estrogen. And progesterone plummets to almost nothing during our perimenopausal transition. So we have this imbalance between the two hormones, our estrogen and progesterone. We make a little bit of progesterone in the adrenal glands, but as the ovaries stop functioning, we make almost none, where we're still making estrogen in fat cells. So this approach also overlooks the importance of other hormones like testosterone, DHEA, or cortisol dysregulation. It's important to understand that not all testing medium shows the same information. It is available to test hormones in blood work, in saliva, and in urine. In blood work, this is the most common thing we're aware of, right? We go to the doctor, we have our labs drawn, it's drawn in blood. But it's important to understand what each of these mediums is showing us. So in blood work, we're seeing total levels of hormones. Total levels are bound. So most of the hormones in blood are bound. They need to be bound to a protein that takes them to the tissues. So over 95% are bound or not active, inactive. For most hormones, we do not have a way to see the small active portion in blood work. And with that, your hormones are fluctuating. They're going up and down. So when we do our blood work, we might get a peak or we might get a trough. It's a snapshot in time of what's happening at that moment. It's not practical for cortisol. If we want to map out somebody's daily cortisol curve, we're not going to send them to the lab 4 times. Plus, research shows us that when we draw blood, it can affect cortisol very quickly and be reflective in our results. Blood work cannot monitor topical hormones, not without excessively dosing someone. And we could do a whole talk on this, but I just want us to understand that when we're looking at topical hormones, they will show low in blood work unless we are giving large amounts. Supraphysiological is what we call that, more than what the body would make, more than what the body needs. So it's that tiny portion, the unbound amount that is available for tissue use that is important here. It's reflective. It's what's in the tissues or not in the tissues that's causing symptoms. This is what saliva shows. It's well established that saliva shows tissue levels or are bioavailable or unbound hormones. Saliva can also be average. So if somebody takes 4 samples of saliva over the course of a day, we can take a little bit from each sample and measure the hormone from there. That means we're not getting a peak and we're not getting a trough, and it's going to correlate more to someone's symptoms. Those multiple collections in one day allow us to graph the cortisol. We're trying to look at a cortisol curve as well, and can accurately reflect topical hormones, or can be used to monitor topical hormones. We can also look at hormones in urine. Honestly, the jury's out on what this is showing. We don't know as a medical community what urine levels are reflective of. There's a lot of teaching and talking out there that they're showing tissue levels and bioavailability, but there's nothing that confirms or proves that. And you will notice that that labs tend to be quite different, or lab results between saliva and urine. What we can see in urine are how the body's breaking down hormones, or our hormone metabolites. So if that's what we want to see, that's where urine is useful. So when do we use these different mediums? They all have their place. It's not that one is better than the other. It's just a matter of knowing when to use each based on what we're looking for. So if we think a woman has some type of a disease state, overactive adrenal glands known as Cushing's, or we're looking for, I don't know, a tumor or something like that, that's where we're going to use our blood work or our serum testing. If we want to monitor injection testosterone or pellet testosterone, that could also be done in serum. So it's usually more pertinent for guys using testosterone. Versus saliva, we can use this for assessing functional hormone imbalance. So we want to see tissue levels, what's in the tissues or not in the tissues that's causing symptoms. So this is for our postmenopausal women who are saying, oh my gosh, I really think it's my hormones. That's where saliva can be very useful. If we want to evaluate the cortisol curve, again, super useful here. And we can use this for monitoring all hormone therapies. This is what we use for monitoring topical hormone therapies. This is the choice if we want to do that accurately. And then urine, we're going to use for assessing metabolites. So let's say we have a woman who's high risk for breast cancer, or a breast cancer survivor, and we want to see how she's breaking down her estrogens. Awesome. We're going to do that in urine. So our bottom line here is that hormone testing can help us identify the cause of symptoms and then help us direct our treatment plan. And it's also useful in monitoring. Salivary testing is the most applicable here for both baseline and monitoring purposes. And not only is it relative, I would argue that hormone testing is imperative. It really provides us that roadmap and also helps people see what's going on with their bodies and increases adherence and accountability. Not all labs are created equal. So we want to do our due diligence in determining who you're going to use. So when we're using salivary testing, I want to see a pooled sample, our consults available. So if you have questions on it, can you reach out? And we want to make sure that lab has integrity, that things are reproducible. The lab that I use for this is Doctor's Data. They do that. They do that pooled sample. So we have an average and we see clinical relative results. Most labs don't do that. They're going to test the sex hormone from the morning sample only. And so if you're doing salivary testing and you're like, wow, this doesn't correlate to her symptoms, it may be something like that. This next one is, I was told I'm too old for hormones. So what do we know? What we do know is that starting hormones before age 60 or within 10 years of menopause is generally considered safer from a risk to benefit profile. Whereas starting more than 10 years after menopause or after age 60, the risk to benefit appears less favorable. So most people coming in and talking to us about hormone therapy are going to be in this age group. Remember, the average age is 51. So, most people are going to fall within this. It's not really going to be that big of an issue. We're not just going to start somebody at 80 on hormones just because, right? And what's really important to remember, is that this is about starting hormones. This is the age for starting hormones. Please do not confuse this with when to end hormones. There is no longer a hard age cutoff. We used to say 60, 65, but recent recommendations from our North American Menopause Society basically said, oops, that thing we said where women should use the lowest amount of hormones for the shortest amount of time, we were wrong. We're doing a disservice to women for quality of life. They can use hormones as long as they and their doctor agree. There's no longer an age cutoff, as long as the estrogen being used is topical. because there's so little risk with that. The previous concern was for cardiovascular events and long-term. Topical estrogen doesn't carry that with it, so no longer an age cutoff. So we're not going to tell our patients that they have to stop at 60. If you are a patient and you've been told you have to stop at 60, reevaluate your healthcare team. Maybe that's true for you for some reason, likely not. So something to consider here is that women can use hormones long time, no longer an age cutoff. That comes from the 2017 position statement from the North American Menopause Society. And in 2022, they updated that, which is very similar to what it was in 2017. Hormone therapy is the most effective treatment for hot flashes, night sweats, that kind of thing, and for concerns of the genitourinary tract. Hormone therapy has been shown to prevent bone loss and fracture. We have the same age differentiations here. And the risks of hormone therapy differ for women depending on the type, the dose, the duration, the delivery, and the timing. Treatment should be individualized with periodic reevaluation. So we're going to get away from the one-size-fits-all approach and base it on the woman. I will not read this whole thing to you, but this comes from the American College of Obstetricians and Gynecologists just in 2024. They are saying that patients deserve a more nuanced approach, an individualized approach, that our conjugated equine estrogens and medroxyprogesterone acetate are no longer the main medications or the medications of choice. All hormones are not equivalent, and we're going to consider treatment with the right formulation at the right dose and time for the right patient, allowing us to recommend safe and effective appropriate treatment for people with perimenopausal and menopausal symptoms. So I love this. What is important to note here is that our FDA requires the same statements, the same risk notification that we put on conjugated equine estrogens and medroxyprogesterone acetate on everything else. And that hasn't been updated. So even though we know topical estrogen is different, it's going to carry the same risk in the package insert. It's going to say the same thing as your Premarin or conjugated equine estrogens. Confusing, but it is what it is right now. Hopefully that changes. This one here we're going to peek at is, I can't use hormones because I have X, migraines, factor V Leiden, a family history of breast cancer. What I want us to know here is that there are very few absolute contraindications to hormone therapy. So an absolute contraindication is a thing that somebody has, a condition someone has, where we say, nope, can't use this medication. Most of the I can't use this because statements that we hear are based off of that outdated information with oral estrogen and progestin use. Topical estradiol and progesterone don't carry the same risk factors and might actually be options for these women. There is an awesome paper that was written. I'm going to show you that here. You see the reference range, or excuse me, the reference to the journal article here. And they do is they identify this between low risk patients, intermediate risk patients, and high risk patients for our treatments. What is important to note here is that for the high risk group, none of these were actually noted as absolute contraindications. It was indicated that we get to make an individualized choice for these patients based off of their history, what you know of them, their relationship, or your relationship, what's available, their own risk profile. So we're going to take this by an individualized account and make sure that all team members agree. So on this high risk, there's even breast cancer and previous history of stroke. So kind of fascinating here. Take everything again on an individualized basis. You have the whole reference here if you want to read that article. When we're thinking about those intermediate risk factors, and I'm not going to go over what those risk factors are, but what I want to point out is what I bolded here. Every one of them, transdermal estrogen preferred, transdermal estrogen preferred, transdermal estrogen preferred. So if we're using estrogen with folks, we are using a topical estrogen for the vast majority of people. And that's the big thing to remember here. Hormone therapy increases the risk of breast cancer. What we know now, this concern came from the original Women's Health Initiative, and that information, as we've seen, is decades old and outdated. The findings suggested a very small increase in breast cancer. Remember, it wasn't even statistically significant. And what we know is that women drinking 3 or more alcoholic beverages per week have higher risk associated than those using the estrogen that we use in the Women's Health Initiative. But that's totally acceptable. That we consider socially acceptable. So there's something to think about there. And our current data suggests that there is not an increase. There might even be a decrease in the risk of breast cancer when we're using estrogen with progesterone. And remember, that was not studied in the Women's Health Initiative. This meta-analysis in 2023 showed that estrogen therapy alone decreases breast cancer incidence and mortality. And estrogen plus progestin increases breast cancer incidence. So we know that the progestin we don't really want to use. We want to use that progesterone. Estrogen only therapy, here's 10 randomized controlled trials that saw women using estrogen were less likely to develop breast cancer than those who did not use hormone therapy. And women who started estrogen earlier saw stronger protective benefits. And it didn't matter what type of estrogen they were using. We know the progestogen matters. I've said this multiple times. This is a French study of almost 80,000 women that saw, compared with non-users, there was no increased risk of breast cancer for women using estrogen with progesterone, but those using estrogen with progestin had an increased risk, which varied depending on the progestin that they were using. There are multiple kinds. Here's another French study showing no risk, and in fact, even a lower risk. And again, a study showing us that progesterone itself is associated with lower risk of breast cancer compared to progestin use. So the bottom line is that all hormone therapies are not equal. Estrogen and progestin is associated with increased risk. Estrogen alone doesn't appear to increase the risk. We don't really want to do estrogen alone for multiple reasons, but estrogen plus progesterone does not increase the risk at all and may even lower the risk. Using hormones increases the risk of heart attack and stroke. What we know now is that, simply put, it doesn't. That might sound confusing. The Women's Health Initiative reported that the risk of stroke and blood clots, including pulmonary embolism, were increased with hormone therapies. But we have 20 years of better understanding here. And this is due to the timing of menopause in relation to hormone therapy use and the delivery method and the hormone that is used. Again, transdermal or topical estrogen, safer than oral; progesterone, safer than progestin. After the Women's Health Initiative, in that study, they just kind of lumped everybody together, but they've gone back and looked at it based on age. So they've done it, they've stratified for age. And we have a longer follow-up. And so what we saw with these new analysis is that the absolute risk of adverse events post-hormone therapy initiation is much lower when we're starting it before 60 than in older women who started it within a decade of menopause. And here, it's stating the same thing. Our cardiovascular risk associated with hormone therapy appears to depend on the timing of initiation in relation to menopause onset. Estrogen can have plaque destabilizing and other adverse effects in the setting of advanced plaque buildup or atherosclerosis. And that's likely when we're swallowing it. So again, something to remind ourselves there. It provides an appropriate and safe option for treatment of menopausal women when initiated in healthy women less than 60 or within 10 years of menopausal onset. So our bottom line, like we've seen in the other statements, is that our topical estrogen has a more favorable profile. It does not increase the overall risk of blood clots. Progesterone has a more favorable profile than progestin, and timing matters. Overall goal of starting hormone therapy is before 60 or within 10 years of menopause. Hormone therapy is too risky or too dangerous. What we know is that women who started hormone therapy in early menopause actually tended to live longer than those who didn't. So a pooled analysis of over 30 clinical trials found that women who began hormone therapy before 60 had a 39% lower risk of death than women who didn't use hormones. Women who use hormones. This is so important to recognize.